All right, let's continue here. You should be able to finish this by the time class is over. So I'm assuming that in the next hour and a half, we'll be finished with this material. Uh, Again, this will be part of a quiz along with chapter 7. So let's take a look at the bone anatomy. And when we look at this bone anatomy material, keep in mind, we've kind of discussed it glancingly previous. So we will kind of discuss again, especially some of these that we're going to give names to in general. An example is the long bones. And you would imagine a long bone would be super long, right? Your metacarpals and your phalanges are considered long bones. So it's not like when we're talking about long bones that it has to be the femur, it has to be the fibula, it has to be the radius and ulna. Long bones can also be your metacarpals, your metatarsals. Those are your long bones as well. Short bones right here are the wrist bones. So lunate, those kind of bones, right? Triquetrum, the hamate, as well as your kneecap right here. Then irregular bones, ethmoid bone, and the sphenoid, and then flat bone. Now the flat bones, you can see they all usually have a specific function, and that's to protect something deep within it. Your ribs, your sternum, those are all flat bones. Your parietal bone are all flat bones. Even the scapula is a flat bone. Now, in terms of the long bones, all long bones have these similarities, right? It's got two ends. Here's one of the proximal. Proximal end is the end closest to your torso. So in terms of your humerus, the head of the humerus, closer towards your torso, that's going to be the proximal end. The distal end will be the one further away. That's your trochlea and capitulum end. So you're going to have two ends, a proximal and distal. The ends are called the epiphysis. Your epiphyseal growth plates are found at the epiphysis, or the ends. The diaphysis is the name of the shaft, right? So the shaft is the diaphysis connecting the two ends, the two epiphyses. And in the ends, we see the epiphyseal growth plate. The growth plate is made out of hyaline cartilage that is present until growth ends at the end of adolescence. Do not get adolescence and puberty mixed up, right? Most women or girls are going to be done with puberty by the time they're in their early teens. A lot of boys aren't done until in their late teens. But some kids keep growing after they're done with their puberty, right? So adolescence is when we have that growth. Puberty is part of the adolescence. It's not all of it. You will hear of people like Kevin Durant. When he went into the NBA, he was 6'10". Now they think he's a 7-footer. He grew a couple inch while he went into NBA. So that does happen from time to time. And it's reason why is because some kids have a longer growth span. And the epiphyseal line is what happens when we have completely replaced the epiphyseal growth plate, and now there's no more cartilage, and all we see is this kind of cracked line. This is one of the ways we can tell if your child is going to have room to grow. Right? Now, most of the time, doctors aren't going to do anything. They're not going to want somebody who's 6'10" just so we can, trying to teach them to get into the NBA or something, right? So we're more worried about kids that are short. And in the old days, we would people would do kind of crazy things, like break apart some of the bones at the epiphyseal growth plate, allow you to kind of separate a little bit, so then you can have healing there and a little bit greater probability of growth. And I've had friends that have kids that do this because they think that they're going to be under 5 foot tall. So if you're under 5 foot tall, it makes it sometimes difficult for just day-to-day things. How do you reach for that top shelf without getting an actual chair or something, right? How do you open that even in our supposedly ADA-proof lab? You guys have seen how tall that latch is to open the drawers, right? It's really high up. So if you're under 5 foot tall, you're not reaching that. And a couple semesters ago, right when they built it, I had a little person. She was about 4'6", right? And there's no way she's reaching it. And obviously, I don't want to. I mean, it's kind of demeaning that they would put it up there when they can actually put it in the bottom and everybody can reach it. Let's talk about the structure of the long bones. And this is interesting stuff right here. The outer layer of a real bone. Again, when are we going to really see a real bone? When you eat, right? So when you eat and you have a drumstick or a thigh, I want you to note just how kind of soft the outside is when it's still kind of, somewhat fresh. It's soft because, and it's kind of wet because it still has an outer layer called the periosteum. The periosteum is an outer fibrous layer of all of our long bones. The inner layer, deep inside, right, is your endosteum. So you have an endosteum deep inside and a periosteum on the outside. The periosteum has 2 layers, an external layer made out of connective tissue, just for protection, and then an internal layer, that's the most important, single layer of osteochondral progenitor cells. Right? Osteochondral, combination, they can turn into osteoblast or chondroblast. Progenitor for stem cells. So these are stem cells that can turn into cartilage-forming cells or bone-forming cells. Then we're going to see the outer fibrous layer also has tendons that becomes continuous with the periosteum. So the fibers are the tendons. And this is what makes, usually when you rip a muscle, you are not going to rip it from its tendon attachment to the bone, right? Why don't you rip it from the tendon attachment to the bone? Because when the tendon goes into the bone matter, it actually becomes part of the bone matter. Example I'll give you guys. Have you ever had a turkey drumstick? When you've had a turkey drumstick and you notice how tough the actual tendons are, the real white thick part, that's the tendons, right? Have you ever tried pulling the tendons off the actual tibia? I know, right? From the drumstick? It's really hard, almost impossible to pull that turkey drumstick tibia, that tendon off the bone. Why? It's because the tendons there become one with the bone. It becomes part of the bone. So it becomes part of the bone material. And because it becomes part of the bone material, you're not going to rip it off. Now, the difference between a drumstick from a turkey and a chicken is that we harvest the chicken at a much younger age. So their tendons aren't quite as dense and as tough yet. So you will be able to rip those off. To make that connection between the tendons and the bone even stronger, we have these Sharpie fibers. These are periosteal fibers that penetrate through the periosteum into the bone. So once a tendon goes into the fibrous periosteum and fuses with the fibrous periosteum, I want you to think of that area that's real strong. We're going to use a nail and just nail it inwards, right? So that area, we're going to have these periosteal fibers, kind of pushes it in and reinforces that connection, making it even stronger, making it harder to remove the tendon from the bone. Now, I said that it's almost impossible, but it's not impossible. It does require, though, some kind of very violent trauma for us to really, rip our tendon from our bone. We call that an avulsion, right? And usually that happens, and I've heard of it from wrestling and football, where somebody's knee is suddenly snapped forward, and then because of that violent force, right, super violent force, you rip the tendon right from the bone, right? Obviously, some people recover quickly. Most of the time, it takes a long time to recover. And for some of the, Desmond Bishop for the Packers had that happen, and he was never the same afterwards. He retired, he came back the next year, then he wasn't as good, so he got cut, went to Minnesota, and he retired the year after, because he just couldn't run anymore because of that. Endosteum, similar to periosteum, but more cellular, lines all internal spaces, including spaces in spongy bone. Again, this is just kind of a graph to show you this is a good definition chart right here, showing you where things are. Now so we started off with the long bone, now flat bones. Flat bones are protective. Think of your sternum, think of your parietal bones. There's no ends, all right? There's no real shaft, so no diaphysis, no epiphysis. Now, we want it to be strong. At the same time, we don't want it to be super heavy. In other words, we don't want it all to be compact bone. You can imagine if your parietal, part of your frontal, part of your occipital bones, those are all type of flat bones. If it was all compact bone, you would double the weight of your skull, right? Making the skull really, really heavy. So to lighten it, we have empty spaces right here full of spongy bone. The spongy bone is still strong, but not quite as strong, but you don't really need the super strength right here. Why? Because we have compact bone superficial, compact bone deep. Now, the compact bone is very smooth. That's one of the reasons why we have it in the deeper areas. If we only had, right, just compact bone and then spongy bone and that's it, no internal layer of this, right? If it's just compact on the outside and then spongy on the inside. Spongy bone is very sharp, right? Really sharp and strong. Your brain would be very, very vulnerable to that sharpened ridges of the spongy bone. So by having the compact bone deep inside, we protect the brain because the compact bone is nice and smooth. Short and irregular bones, compact bone as well on the outside surrounds the spongy center, similar to the epiphysis of the long bones. Now again, the irregular ones are these right here. So you have compact bone on the outside, spongy deep inside. Again, always lightening but protecting the brain. Now, probably the toughest concept we'll talk about in this chapter are these ossification types. Intermembranous, endochondral. Even then, it's not too bad, I promise you. Right? These are the two ways we form bone in utero. That's the big thing right here. This is during fetal development, right? We have intermembranous ossification and endochondral ossification. Well, endochondral has the root chondral in it, meaning it's got something to do with cartilage, right? So what we're going to see in endochondral, we're actually going to make your bones out of cartilage first, and then replace it with bone tissue in a couple months. So we're going to see this early in gestation. All of our long bones are going to be made out of cartilage. And then we replace it with bone material almost from top to bottom, except for a couple of areas where we don't replace it. Now, intermembranous ossification, you don't have this cartilage template that you make first. You just have bone cells or stem cells go to the area where you need bone. Those stem cells then turn into osteochondral progenitor cells, and they start forming bone matter immediately. Right? It's a one-step process for intermembranous ossification. No intermediate stage of cartilage formation first. Both methods of ossification at first produces woven bone. Then that bone is remodeled to the stronger compact bone and spongy bones that we're going to see. After remodeling, this is a big one in here. After remodeling, formation cannot be distinguished one from another. If we look at the bones, we can't tell how we make it, right? It's not like we can look at the bone of a clavicle and say, oh, that's made intermembranously. And then, right, we can't tell. It's just when we first produce it, there's two different ways of producing it. So in intermembranous ossification, we're going to see that we have a connective tissue membrane. And here's probably the easiest one right here, right? You're going to see there's not a lot of areas in our body where we have intramembranous ossification. We only see it in a few different areas, right? Forms many of the skull bones, frontal parietal bones, forms part of the mandible, or part of the clavicle. That's it. So in other words, in the skull, part of the jaw, part of your clavicle, and that's it, your collarbone. That's it, right? So with this intermembranous ossification, we're going to have embryonic mesenchymal cells. Embryonic mesenchymal cells are immature pluripotential stem cells, meaning these stem cells can become anything, right? They can become skin cells later on. They can become any type of epithelial cells. It can become cartilage-forming cells. So these pluripotential stem cells, they can inherently become just about anything as long as they get the proper direction. These stem cells migrate to the site where you need the bone and then immediately divide. So the stem cells divide. One always stays a stem cell. One then turns into an osteoblast, right? We always divide before we differentiate, meaning that you have a stem cell. If we want to turn into an osteoblast, what we're going to do is, if we just have that stem cell turn into an osteoblast, you got rid of your stem cell. Sure, you have an osteoblast now, but what's more important, the stem cell or the osteoblast? Well, the stem cell is, right? So before the stem cell gets a message to turn into osteoblast, it will reproduce. It'll undergo mitosis. One of the stem cells stays a stem cell. The other daughter cell turns into the osteoblast. That way you never get rid of your stem cell line, right? If you need more osteoblasts, that one stem cell divides again. One of those cells, after division, stays a stem cell. The other one then turns into osteoblast again. We never get rid of the stem cell line. Now, with this kind of production right here, again, you start forming bone tissue immediately. As you start forming bone tissue, like these cells, these osteocytes, that's all older bone cells that's already produced bone tissue here. Then these cells will start forming bone tissue, and now the bone tissue that we are building is going to be enlarged. Eventually, you're going to start producing just bones in that area, a large amount of it. Now, where do we see intermembranous ossification? Again, parietal bone, frontal bone, part of your occipital bone, part of your mandible, and part of your clavicle. That's it, all right? Now, endochondral ossification is the bone formation for the rest of the bones, including all of our long bones, right? Bones on the base of the skull, mandible, the epiphysis of the clavicle, and all of our long bones undergo endochondral ossification. Your ribs, your sternum, right? Your hip, your scapula, all undergo endochondral ossification. With endochondral ossification, we have cartilage formation first, and it begins at the end of the 4th week of development. So we're talking about really early on, right? 4th week of development here. Then we start replacing it at about the 2nd trimester, right? As we start replacing that bone, some areas we replace it right away, right? So about 8 weeks in, we start seeing the migration of the cells there, right? At about the start of the 2nd trimester, you start replacing all that cartilage material with bone tissue. For some people, we don't finish until later, 18 to 20 years of age. It's a two-step process, beginning with mesenchymal stem cells. Again, right, those stem cells migrate to all the areas where we need the bones. As they migrate, they then form a perichondrial layer, and those stem cells undergo mitosis. One of those stem cells that is produced by mitosis turns into a chondroblast, right? So you form a chondroblast and you start laying down cartilage first. The cartilage then forms a cartilage template. The cartilage then will be replaced later with bone tissue. So let's see what it looks like right away. So you have these cells, the mesenchymal cells, right? They're gonna start to migrate to the site where you actually need the bone. As you migrate to that site, they form this collar on the outside right here. And then those stem cells undergo mitosis to become chondroblasts. The chondroblasts start building up this bone, and now we're going to have the start of our long bone, the template that we're going to use. Then what we're going to see as about the end of the 8th week, you'll see some of the cartilage area start to die off, right? Now this isn't, like a necrotic kind of event, right? This is a programmed cell death. They're supposed to die. As the area of cartilage material starts to die off right here, you're going to have a blood vessel penetrate through. As it penetrates through, you're going to start bringing osteoclasts and osteoblasts here. So those osteoblasts come right here, and they start to replace this cartilage material with bone material. So you need an area where the actual cartilage area dies off, so then a blood vessel can penetrate through. Once a blood vessel penetrates through, we're going to stimulate, so then the cartilage material is replaced with bone material. So it happens from the middle of our long bones, and then it migrates upwards and downwards in both directions. So then as we replace it, you slowly replace that cartilage going upwards towards the proximal epiphysis and downwards towards the distal epiphysis. Now, what happens then? At the epiphysis area, the proximal and the distal, you have the same thing happening, where you have a cluster of cells here start to die off, just like what we see here in the beginning, right? This is called, right here, right, a secondary bone forming area. So you have these clusters found at the ends where the actual cartilage material starts to die off. Then new blood vessels penetrate. See that? So you need that penetration of blood vessels to bring osteoclasts, right? To bring calcium, to bring the phosphates. Without the blood vessel penetrating, you're not going to get calcium phosphate into that region to form bone. So you need that penetration of the blood vessel along that secondary ossification centers on the ends. And what happens, right? The primary ossification center occurs in the middle of the shaft or diaphysis, and it spreads upwards and downwards towards the ends. At the ends, though, it stops, right? So it migrates up here this way, and then it stops. In order to ossify the epiphysis, we need the secondary ossification center, right? As that kind of cell death occurs for the cartilage, a blood vessel penetrates through, and the secondary ossification center is seen at the epiphysis. And now osteoclast removes the cartilage, osteoblast starts forming bone in that area. So then what was this top area that was all cartilage, now we're replacing it from bone. And now we're going to see, you're going to have bone at the end, bone on the bottom, where the primary ossification center was, right? And then there's an area in between those two regions that we don't replace with bone yet. That area of cartilage we don't replace with bone is your epiphyseal growth plate. So your epiphyseal growth plate is determined in the second trimester of your life. Basically, your height is determined in the second trimester of your life. And if all of your nutrition levels are at its maximum, you will gain full adult height that you should get to, right? But you need good nutrition to get that. Again, there are areas where we don't replace with bone tissue. And one of those areas is that it spans where the epiphysis and the diaphysis meets, right? That area of cartilage becomes your epiphyseal growth plate. And then the second area that we don't replace with bone tissue is at the very ends. That becomes our articular cartilage. That articular cartilage that I just mentioned previously, that wears down with age, right? So then we're gonna have bone-on-bone contact. In some people with degenerative arthritis, it wears down even faster. Well, that articulating cartilage has been there since the second trimester of life. It never grows, it never gets replaced. Whatever you had early on is what you will have for the rest of your life. And hopefully we have a nice full amount of this articular cartilage right here. Now, bone growth is going to be very similar to cartilage growth. Just be careful because we use the same names. Right? Now, in order for bones to grow in length, we're going to see cartilage needs to grow as well. Right? In order for a growth in length to occur at the epiphyseal growth plate, we need cartilage growth. So let's take a look what I mean by this. Right? So in terms of bone growth, it involves formation of new cartilage, right? And occurs at the growth plates. Growth of cartilage on the superior and inferior ends allows for growth of the bones bilaterally. In other words, right, you have two ends, two epiphyses. We don't want just one end to get longer and the other one staying the same. So in terms of growth, we want both ends to start growing. So then you'll have good growth in both directions. So the distal end will grow down. The proximal end will grow upwards. So then you have nice equal growth in both directions. This is what we mean by bilateral growth. Bilateral growth, right, is going to be called interstitial growth in terms of bone. Now, once we have gained our full adult height, then we're going to start to see a growth in width, right? That's called appositional growth in terms of bone. Again, it's complete opposite of cartilage. Closure of the epiphyseal plate occurs as we ossify the growth plate, and then we'll have an epiphyseal line seen. Usually occurs, there's a huge range, between 12 and 25. Sex plays a big difference, genetics plays a big difference. All right, nutrition plays a big difference. Now, the only areas where we never replace with bone tissue is this articular cartilage area. Again, appositional growth only occurs after closure of the growth plate. Appositional growth in bone is growth in width. Appositional growth occurs throughout one's lifespan after adolescence. And we'll talk about certain athletes and certain people that do growth hormones and what happens to their body as they do these growth hormones to get bigger and stronger for bodybuilding, right? For any of the sports that they do. So when we look at the epiphyseal plate, on this side, here's a picture. All we're doing with this picture of the epiphyseal plate is taking this one area right here, right here, where we have the bone from the shaft, right? And then we'll have the start of our cartilage down here, right? And we're magnifying it here and taking a look at it. So you have bone matter down here, cartilage up here. And what we're going to see is this, right? As bones grow, the cartilage actually kind of rises and grows upwards first. As the cartilage grows up, the bone underneath starts to replace the older cartilage on the bottom. So the more cartilage growth occurs, the greater the probability of bone growth, the greater chance of you getting much taller, right? You've heard about, certain players, right? Anthony Davis was like 6'2", 6'3", unwanted guard from Chicago, and he grew like 8 inches over a summer, right? Then comes 6'10", 6'11", right? Went to Kentucky for a year, right? That massive growth in some people, just because you have this huge growth in the cartilage on all of the long bones. So you grow the cartilage upwards, bone starts to replace it from the bottom. The more cartilage growth you have, the more probability of bone growth, right? That occurs at the proximal end. On the distal end, the cartilage grows down. Bone replaces from the bottom, right? So then you're growing in both directions. So when we look at this, you need that cartilage growth for that bone growth to occur. If you don't have the cartilage growth, then bone growth will not occur. Yep, just after, right, once we're done. Question?
Yeah, it was about this.
Yeah, I know, we're taping, so, all right. In terms of this right here, right, if you take a look at this picture, there's that small break, and it looks like it's a break completely. Now, why does it look like it's broken? Simple. Cartilage does not have any calcium. Because of that, it doesn't reflect the x-rays. Bone does. Bone is really dense. The x-rays don't get through. They get absorbed, right? So what happens, it looks very white here. Cartilage looks like it's black, right? Looks like it's a broken bone right here. In reality, if you have a broken bone throughout this whole area, people will be screaming in pain, right? So this is a sign that this is the epiphyseal growth plate. Now, when we look at the growth plates in kids, when we see like a large area of the growth plate, we know they have a large room for growth. That's one of the ways that they can tell generally how tall a child will be. Now, once we're done with this, then I'll answer questions just because, right? In terms of this area right here, again, right, you're gonna have growth of the cartilage upwards. So this is the proximal end of your tibia. And what happens? The cartilage on top here grows up. As the cartilage on top here grows upwards, now you have more cartilage over here. That layer of cartilage has grown. As you have the buildup of cartilage upwards, bone from the bottom starts to replace. So then bone starts to move upwards as well. So the more cartilage grows, the more bone that can replace. Perfect, right? Eventually though, what happens? Eventually the cartilage growth slows down. The bone growth accelerates, and then you seal the plate as the bone growth overwhelms the cartilage growth. Now, there are ways that we can make sure people get slightly taller than like 4'10", right? Usually 4'10", that's the barrier before some doctors will start treating. We can give kids, right, certain amount of growth hormone before they're done growing. That growth hormone will hopefully accelerate the growth of the cartilage. Now, you guys have heard of people that are pituitary giants. These are people that are huge, like him, right? Now, Robert, there's a person, the tallest person ever lived was 9 foot tall. And what happened was that he had an actual growth in his pituitary gland. And at a young age, he started overproducing growth hormone, right? If you give somebody growth hormone like that, or they have much more growth hormone than a typical person, at a young age, you will always have cartilage to grow up. He never stopped growing, right? Even at 9 foot tall, he didn't stop growing. He died early in his life, in his mid-40s, because he was so tall that circulation became a problem, right? It's always hard to move blood against gravity back to the heart. You can imagine, if your heart was like me, it's pretty short, right? Not a very far distance. If it's like him, and you're 9 foot tall, right? That's a long distance to move blood against gravity back to your heart. He got infection in his foot, got sepsis, and he died because of it. Now, again, right? In terms of this growth and length, you need growth of the cartilage here on the proximal side. Again, on the proximal, the cartilage grows up. As it grows up, on the proximal side, bone growth occurs upwards. On the opposite side, the distal side. So if this is a tibia, the opposite side is a part with the ankle. Well, the cartilage will grow down. So then you have equal growth in both directions. Now, once we're done growing the bone in length, we need to make it a little bit wider and stronger, right? That is growth in width. And this growth in width is our, right, interstitial growth, appositional growth, right here. And appositional growth occurs after we have attained our full adult height. Appositional growth occurs when you have a lot of nutrition and, in some people, a lot of growth hormone. Now, if you give somebody growth hormone before they enter puberty, before they hit the closure of the plates, that person will get taller. After you've already kind of, closed the growth plate, giving somebody growth hormone will not make them taller. What it'll do is make the bones thicker, right? So this appositional growth and the interstitial growth, right? This is the growth in width right here. What we're gonna do is, to make the bones bigger and wider, we're gonna lay down a blood vessel at the very end, right? So you have, this is the end of our bone right here. I'm gonna lay a blood vessel down. As we lay a blood vessel downwards, what happens? Right? What happens is osteoblast starts to surround the blood vessel. As these osteoblasts starts to surround the blood vessel, I'm gonna extend the bone tissue outwards, right here. As you surround it, then the osteoblast starts to lay new bone material around the blood vessel, and now I have made this bone material a little bit wider and thicker, right? This is appositional growth. So in terms of the quiz, note just a difference between those two growths, right? One allows for growth in width, appositional. Now, once we hit a full adult height, this growth occurs from that point on. Now, examples of this growth, right? You guys ever heard of Mark McGwire? He was this baseball player. Now, obviously, we have to use examples of athletes, because most people that are going to take growth hormones are going to be athletes, right? So what happens if you're an athlete and you take growth hormone? Well, Mark McGwire, when he went into the major leagues, he wore a size 8 hat and pretty big hands, so size 7.5 gloves. Pretty big hands, right? Maybe even bigger. I think it was like 8.5 gloves, right? So he's a full adult. Well, what happened was he started taking growth hormone and steroids. The growth hormone, what did it do? Well, his hat size increased, right? From an 8 to 8.5. Should your hat size increase if you are not a child? No, right? Your head should not generally just get larger, right? But his got larger. He needed a much larger hat size. His glove size increased as well. Should that happen? No. Why did it happen? Because when you're taking growth hormone, you're gonna accelerate the appositional growth. The bones get thicker. All the bones of your body gets thicker, right? Now, what was even more telling was what happened when he stopped playing baseball. When he stopped playing baseball, he no longer took growth hormone. His hat size went back down again to 8, right? His glove size went back down again, and he looked more normal, right? That's why if you ever seen bodybuilders, their heads are really big, right? Their foreheads are really pronounced. Well, growth hormone is going to increase your bone in width. Now, what else? Sometimes this growth hormone is helpful. Who would be a population that would be helped by growth hormone? Older people. Older people, we're worried about their bone density, right? We're worried about osteoporosis. So we should give them a little bit of HGH. By the way, this is where those Major League Baseball players got all of the growth hormone, was in clinics that catered to the elderly and the aging population, right? And what happened, I mean, we can talk about the morality of it, but if I was a baseball player and I can make $80 million, $100 million, right, just by taking growth hormone and set your family up for multiple generations, that's really hard for me to say no, isn't it? All right? So, to be honest, I mean, people that say, oh, they cheated. No, I mean, you're cheating what, right? What game, right? So that's the thing that I want people to understand. There is a good point with taking growth hormone, especially people with decreased bone density, right? Now, anabolic steroids also has its usefulness, but not to the same extent as we see with growth hormone. Right, I'll stop right here for a few minutes.